Protein energy malnutrition is a range of clinico-pathological condition arising from lack of varying proportions of protein and calories, occurring most frequently in young infants and young children, and is usually associated with infection. Severe acute malnutrition or SAM. Severe acute malnutrition or SAM. It is defined by the presence of severe wasting, low weight for height, and or bipedal edema. It is defined by the presence of severe wasting, example, low weight for height, WHZ less than -3, MUAC mid upper arm circumference less than 115 millimeter, or bipedal edema. Severe wasting and bipedal edema. Severe wasting measure weight for height, Z score, weight for length, Z score. Criteria, clinical features of SAM: clinical aged before 6 to 60 months. Severe wasting, weight for height, Z score, and weight for length, Z score, cutoff less than -3 SD. Severe wasting, another criteria: mid upper arm circumference, MUAC less than 115. Bipedal edema, clinical sign, it is present. Now children less than 6 months. Weight for length, Z score, less than -3 SD. Visible wasting and bipedal edema. Treatment of severe protein energy malnutrition or malnutrition. Treatment: 10-step management. Number first step: treat or prevent hypoglycemia. Treat or prevent hypoglycemia. Treat or prevent hypoglycemia. Number 2, treat or prevent hypothermia. Step 2. Step 3, treat or prevent dehydration. Number 4, correction of electrolyte imbalance. Number 5, treat or prevent infection. Number 6, correct micronutrient deficiency. Step 7, start feeding cautiously. Number 8, acid catch-up growth. Number 8. Number 9, Provide sensory stimulation and emotional support. Provide sensory stimulation and emotional support. Provide sensory stimulation and emotional support. Number 10, prepare for discharge and follow-up after recovery. Prepare for discharge and follow-up after recovery. Prepare for discharge and follow-up after recovery. Step 1, treatment of severe protein allergy malnutrition. Step 1, treat or prevent hypoglycemia. Treat or prevent hypoglycemia by give 50 milli of 10% glucose orally or NG tube, or milli per kg of 10% glucose IV. Start and continue 2 hourly feed day and night. 2 hourly feed day and night. Treatment number 2, treat or prevent hypothermia by warm the child. Warm the child. Clothe the child including head cover with a warm blanket and increasing the ambient temperature with safe heat source, or put the child on the mother's bare chest for skin to skin contact and cover them. This is called kangaroo mother. Number 2, ensure child is covered at all time, especially the night, and keep away from the cold air. Number 3, avoid prolonged exposure for examination and procedure. Avoid prolonged exposure for examination and procedure. Step 3, treat or prevent dehydration. Treat or prevent dehydration by give Resomal 5 milli per kg orally or by NG tube every 30 minutes for first 2 hours. Then Resomal 5 to 10 milli per kg per hour. Then Resomal 5 to 10 milli per kg per hour, alternatively with F75 for 4 to 10 hours. Until the child rehydrated. Do not use IV route for rehydration. Except in case of shock, and do so with care. Otherwise, it may lead to fluid overload and heart failure. Step 4, correction of electrolyte. Imbalance. Number 5, treat or prevent infection with broad spectrum antibiotics. Oral amoxicillin or cotrimoxazole. Since to IV antibiotics when no clinical improvement, lethargy, fever, persistence of fever by 48 hours, deteriorates after 24 hours, presents with septic shock or meningitis. Number 6, correct micronutrient deficiency. Deficiencies by supplementing vitamin A, multivitamin, folic acid, zinc, copper, or at least 2 weeks. Iron is given in rehabilitation phase. Iron is given in rehabilitation phase. Feeding. Start feeding cautiously by small amount and frequent oral or NGTU feed. Small amount and frequent oral or NGTU feed. Start feeding with F75 therapeutic meal in the stabilization phase. Start feeding with F75 therapeutic meal in the stabilization phase, 2 to 3 hourly orally or through NG tube. Encourage breastfeeding. Allocate daily fluid at 120 to 130 milli per kg. 120 to 130 milli per kg. Step 8. Acid catch-up growth. About 1 week after admission, when appetite returns, edema disappears, since F75 to F100 therapeutic milk. F75 to F100 therapeutic milk. Weight gain should be monitored to assess response. Weight gain should be monitored to assess response. Provides number 9 provides sensory stimulation and emotional support by providing tender, loving care, a cheerful, stimulating environment, and structured play therapy and others. Number 10, prepare for discharge and follow-up after recovery. Discharge criteria. Child discharge criteria of child. Weight for height Z. Weight for height Z greater equal -2. Edema has resolved. Gaining weight at normal or increased weight. Eating at an adequate amount of nutritious food that mother can prepare at home. All infections and complications have been treated. Provided with micronutrient. Immunization updated. Now, discharge criteria of caregiver. Knows how to prepare appropriate foods and feed to the child. Knows how to prepare appropriate food and feed to the child. Knows how to make appropriate toys and to play with the child. Knows how to give home treatment of common ailments and can recognize danger signs. Vitamins and minerals used to treat severe acute malnutrition. Vitamins and minerals used to treat severe acute malnutrition. Vitamin A, multivitamin, folic acid, zinc, copper. Vitamin A, multivitamin, folic acid, zinc and copper. Vitamin A, multivitamin, folic acid, zinc and copper. Now, complications of protein energy malnutrition. Complications of protein energy malnutrition. Infections, both overt and hidden. Infections, then dehydration and dyselectrolytemia. Dehydration, hypoglycemia, hypothermia, anemia, congestive heart failure, bleeding, xerophthalmia and blindness, sudden infant death syndrome, sudden infant death syndrome.